Clinical thresholds in late pregnancy, a teetering edge. In the third trimester of pregnancy, certain medical conditions may arise that place the birther's life at imminent risk. These include severe preeclampsia, cardiac failure, disseminated intravascular coagulation, sepsis, or placental abruption. In such cases, the continuation of pregnancy, even for hours, may increase the likelihood of maternal death. So, why then would an abortion ever be the option of choice? Let's think of the 1% of possibilities, a rarity among the entities with uncertain futures. What events could happen at such an incident ratio to cause it to be a necessity? Surely these issues would be addressed in an earlier stage. Correct? First, let's get clear on some definitions. If the fetus is alive but non-viable, and the pregnancy is intentionally ended, it is still classified as an abortion even if the fetus shows signs of life briefly. If the fetus dies spontaneously and is then delivered, it is a stillbirth. If the fetus is non-viable due to anomaly and the pregnancy is ended for that reason, it is an abortion, not a stillbirth, even if the fetus is born with a heartbeat. In most third trimester emergencies, delivery is the cure, especially for conditions like HELLP, preeclampsia, or fetal distress. But in rare cases where the fetus is non-viable caused by hydrops fetalis with cardiac failure, severe growth restriction with absent blood flow, anencephaly, absence of major portions of the brain and skull, bilateral renal agenesis, no kidneys, leading to no amniotic fluid and underdeveloped lungs, thanatophoric dysplasia, severe skeletal disorder incompatible with breathing. These fetuses may be alive in utero but will die shortly after birth or during labor. May be technically alive but physiologically unsustainable. Delivery itself is too dangerous or too slow. The commonly cited nature of these abortions is that it's a 3-day process, but this is not universal. It's a safety protocol shaped by fetal viability, cervical readiness, maternal stability, legal and ethical safeguards. Expedited pathways are used when time is critical, fetal demise is confirmed, or maternal survival depends on rapid intervention. These abortions are called induction abortion. This method may take several days and is performed in a hospital setting under close supervision. Stage 1. Fetal demise if required. Intracardiac injection, digoxin or potassium chloride may be administered to stop the fetal heartbeat before the procedure. This step is often required by law or institutional policy to avoid signs of life during delivery. Stage 2. Medications, misoprostol, mifepristone, and/or oxytocin to induce labor contractions. Duration may take 12 to 48 hours. Outcome, vaginal delivery of fetus and placenta. Additionally, dilation and evacuation D&E may be used in the third trimester. Cervical preparation, laminaria or misoprostol used to dilate cervix over 1 to 2 days. Surgical removal, fetal tissue removed via suction and forceps under anesthesia. A key point to be made is that the removal of fetal tissue more often than not occurs after the fetus's life ends, meaning this is not the step which a living fetus has occurred to it. It is only the means by which the body of a formerly living fetus's parts are removed. Though data does vary, the majority is evident, and to do otherwise is illegal in some states. Typically performed up to 28 to 30 weeks in specialized settings. An emergency peripartum hysterectomy, EPH, is the surgical removal of the uterus performed during or shortly after pregnancy to control severe, life-threatening hemorrhage that cannot be stopped by other methods. It is a last resort to save the mother's life and is most often caused by abnormal placenta conditions, such as placenta accreta, and is increasingly common due to the rise in cesarean deliveries. While a potentially life-saving procedure, EPH carries significant risks for the mother and results in the loss of fertility. Pregnancy emergency surgeries include emergency C-sections for rapid delivery due to maternal or fetal risk, and ex utero intrapartum treatment procedures where the baby is partially delivered and receives immediate intervention while still connected to the placenta. Other emergency surgeries, like those for appendicitis, also occur but are less specific to fetal delivery itself. The goal is to stabilize both mother and fetus, manage complications like blocked airways, and provide surgical treatment for conditions that would be dangerous if left until after birth. Emergency delivery procedures. Emergency C-section, a rapid, unplanned surgical delivery when there is a critical threat to the mother's or baby's health. Exit procedure, a specialized, planned surgical delivery that allows surgeons to perform critical interventions on the fetus while it is still attached to the placenta and connected to the mother's blood supply. Purpose: to address life-threatening fetal conditions like airway blockages, large neck tumors, or severe heart-lung problems that would make breathing impossible immediately after birth. Process: the mother is put under general anesthesia. A modified C-section incision is made, the baby is partially delivered, head and shoulders, but remains attached to the umbilical cord and placenta. Surgeons then perform necessary procedures, such as securing the baby's airway. As many agree, these third trimester abortions are undesirable and further morally challenging. It is expected to get the abortion as early as possible once the intention to do so is made within a consideration period of roughly 3 days and best access is attainable. Let's look to the future. What if an abortion takes place? It was a cryptic pregnancy with no genetic screening and additional care. What if we had a situation where a mother wanted a blind at-home birth and only came to the hospital with complications? Let's investigate casualties of the rarity and speak to its merit and what you would do when faced with such conditions. Moreover, what would you do to prevent them? Third trimester screening. The third trimester marks a critical phase in prenatal care, where screening shifts from general monitoring to targeted assessments of fetal well-being and risk. Several conditions that emerge or escalate during this period, particularly those involving placental dysfunction, fetal growth restriction, and maternal-fetal antigen incompatibility, carry significant risk of fetal morbidity and mortality if left unmanaged. Key screenings include umbilical artery Doppler velocimetry, used to detect elevated resistance in placental blood flow. Abnormal results are found in approximately 15 to 30% of pregnancies affected by fetal growth restriction, with an associated stillbirth risk of 1.5 to 2.5% if not addressed. Biophysical profile, which combines ultrasound and non-stress testing to evaluate fetal movement, tone, breathing, and amniotic fluid. A score of less than or equal to 4 is considered abnormal and correlates with a 10% risk of stillbirth within 1 week if no intervention occurs. Non-stress test, which monitors fetal heart rate in response to movement. While most tests are reactive, persistent non-reactivity occurs in about 10% of cases and may indicate hypoxia. If unmanaged, this can lead to a 1 to 2% perinatal mortality rate. Middle cerebral artery, MCA, Doppler, particularly relevant in cases of maternal alloimmunization, for example, Rh or Kell disease assesses fetal anemia. In severe cases, untreated fetal anemia can result in hydrops fetalis and a fatality rate of up to 50%. MCA Doppler is used routinely in sensitized pregnancies to guide timing of intrauterine transfusion or early delivery. Maternal alloimmunization panels, which identify antibodies against paternally inherited fetal antigens. These screenings are essential in Rh-negative mothers and those with prior sensitization. Severe cases of hemolytic disease of the fetus and newborn, HDFN, can be fatal without intervention. Group B streptococcus, GBS, screening, performed between 35 to 37 weeks, identifies maternal colonization. While colonization occurs in approximately 25% of pregnancies, only 0.2 to 0.4% of newborns develop invasive infection. Among those infected, the fatality rate is approximately 4 to 6% without antibiotic prophylaxis during labor. When aggregated, these conditions contribute to an estimated 0.74 to 1.6 fetal deaths per 100 pregnancies if left unmanaged. However, with timely screening and intervention, most of these risks can be substantially reduced. This chapter underscores the importance of third trimester surveillance, not only for maternal health, but for identifying and mitigating fetal risks, many of which stem from placental function and paternal antigen incompatibility. These screenings are not optional. They are essential tools for preventing avoidable loss and guiding clinical decision-making in the final weeks of pregnancy. When surgical intervention is considered, cesarean delivery is often the default. However, C-section is a major abdominal surgery involving incisions through the skin, muscle, and uterus. It requires anesthesia and carries risks of hemorrhage, infection, and long-term complications. For some patients, especially those with clotting disorders, cardiac instability, or systemic infection, surgery may be contraindicated or incompatible with survival. In these scenarios, third trimester abortion may be medically indicated. This procedure typically involves a multi-day process of cervical dilation, uterine preparation, and monitored evacuation. It allows for continuous surveillance and staged intervention, reducing physiological stress and enabling rapid response if the patient's condition deteriorates. If fetal viability is present, emergency extraction may be attempted during the abortion process. However, the primary clinical objective remains maternal survival. The fetus may be delivered alive, but this outcome is secondary to stabilizing the birther. These decisions are made within a framework of medical ethics, legal constraints, and patient consent. They are rare, complex, and often occur in specialized care settings. The goal is not to choose between life and death, but to navigate a threshold of intervention. Maternal mortality is not confined to the moment of birth. In the United States, approximately 22% of pregnancy-related deaths occur during pregnancy, 13% on the day of delivery, and nearly 40% in the postpartum period, most within the first 2 weeks. These deaths often result from hemorrhage, hypertensive disorders, infection, cardiomyopathy, or embolism. Many are preventable. The postpartum phase, though medically vulnerable, is frequently under-monitored. Insurance policies may discharge birthers within 48 to 96 hours, long before complications manifest. Follow-up care is typically scheduled at 6 weeks, leaving a critical gap in surveillance. Failures of detection arise from subtle symptoms, systemic bias, and fragmented care. Fatigue may mask heart failure, pain may signal infection, elevated blood pressure may go unmeasured. In marginalized populations, these signals are more likely to be dismissed. Recommendations include earlier postpartum check-ins, extended monitoring for high-risk patients, and improved clinician training in symptom recognition. The postpartum period is not a resolution. It is a continuation of risk, deserving of vigilance equal to labor itself. In some regions, the teetering ledge becomes more than metaphor, it becomes a trap. When pregnancy reaches its final trimester and complications arise, the difference between life and death may hinge on access to surgical care. But in conflict zones, remote areas, or under restrictive legal frameworks, that access may vanish. Here, the birther may be unaware of the pregnancy, unable to seek help, or actively denied intervention. A C-section, often the definitive response to obstructed labor, hemorrhage, or fetal distress, may be unavailable, delayed, or legally prohibited. The body continues its descent unsupported. In these blind instances, the ledge is surpassed not by choice but by absence. The birther may die from conditions that are resolvable elsewhere: uterine rupture, eclampsia, sepsis. The fetus may perish in tandem or survive into trauma. The threshold is no longer a place of decision, it is a place of abandonment. This is not a failure of medicine. It is a failure of infrastructure, of policy, of recognition, and it transforms a survivable crisis into a fatal inevitability. Scenario: unrecognized pregnancy and delayed surgical access. A 32-year-old woman arrives at a community hospital with severe abdominal pain, nausea, and elevated blood pressure. She has a history of irregular cycles and has not received prenatal care. She does not believe she is pregnant. Upon examination, clinicians discover she is approximately 34 weeks pregnant. The fetus is viable, but the birther is showing signs of preeclampsia. Her blood pressure is dangerously high, and protein is present in her urine. She is at risk for seizure, stroke, and organ failure. The hospital does not have an obstetric surgical team on site. Transfer to a tertiary care center is requested but delayed due to weather and capacity issues. Meanwhile, her condition worsens. She begins to experience visual disturbances and shortness of breath, early signs of eclampsia. Because the pregnancy was unrecognized, no prior monitoring was done. The fetus is in breech position, and labor has begun spontaneously. A C-section is medically indicated but cannot be performed safely at the current facility. Induction is attempted but fails to progress. The birther begins to seize. By the time she is transferred, she is in multi-organ failure. Emergency surgery is performed, but she dies in the operating room. The fetus is delivered alive but requires intensive neonatal care. Scenario: stabilization through controlled intervention. A 32-year-old woman arrives at a regional hospital with severe abdominal pain, elevated blood pressure, and shortness of breath. She has not received prenatal care and was unaware she was pregnant. Upon evaluation, clinicians determine she is approximately 34 weeks pregnant. The fetus is viable but in breech position, and the birther is showing signs of early eclampsia and cardiac strain. Due to her unstable condition, a cesarean section is deemed too risky. She is transferred to a tertiary care center equipped for high-risk obstetric management. There, a third trimester abortion protocol is initiated not as a termination of choice, but as a controlled intervention to prevent maternal collapse. Over 3 days, her cervix is gently dilated, her vitals are continuously monitored, and medications are administered to manage blood pressure and prevent seizures. On the 3rd day, uterine evacuation is performed. The fetus is delivered without signs of life. The birther survives. Her cardiac function stabilizes and she is discharged after several days of observation. The fetus, though viable at the time of admission, did not survive the process. The clinical team documents that the intervention prevented maternal death and was medically necessary given the risks of continued gestation and surgical incompatibility. Scenario: uncertain fetal viability and maternal instability. A 28-year-old patient presents to a high-risk obstetric unit with severe headaches, elevated blood pressure, and visual disturbances. She is approximately 32 weeks pregnant, confirmed by ultrasound. The fetus shows signs of growth restriction and intermittent heart rate decelerations. Viability is uncertain. Survival outside the womb may be possible, but prognosis is poor. The birther is diagnosed with early eclampsia and suspected HELLP syndrome, a life-threatening condition involving liver dysfunction and low platelets. Her clotting profile is unstable, and her oxygen saturation is declining. A cesarean section is considered, but surgical risk is high due to potential hemorrhage and anesthesia complications. The care team initiates a 3rd trimester abortion protocol not as a termination of choice, but as a staged medical intervention to preserve maternal life. Over 48 hours, the cervix is dilated and the birther is monitored continuously. Medications are administered to stabilize her vitals and reduce seizure risk. On the 3rd day, uterine evacuation is performed. The fetus is delivered with a weak heartbeat and transferred to neonatal intensive care. Despite resuscitation efforts, the fetus dies within hours. The birther survives, with liver function gradually improving and blood pressure stabilizing. This scenario reflects the complexity of late pregnancy interventions, when fetal viability is uncertain and maternal survival is at stake. The decision is not binary, it is layered, time-sensitive, and shaped by physiological thresholds that shift hour by hour. Scenario: clotting instability and the calculus of survival. A 35-year-old patient arrives at a tertiary care center at 33 weeks gestation with severe headaches, blurred vision, and swelling. Her blood pressure is elevated, and lab results reveal early signs of HELLP syndrome, hemolysis, elevated liver enzymes, and low platelets. Her clotting profile is unstable, platelet count is dropping, fibrinogen is low, and D-dimer levels are rising. She is at risk for disseminated intravascular coagulation, DIC, a condition where the body's clotting mechanisms spiral into hemorrhage. The fetus is viable but growth restricted. A cesarean section is proposed initially, but the surgical team warns that her clotting status makes anesthesia and incision dangerous. The risk of uncontrolled bleeding is high, and her liver function is deteriorating. The maternal fetal medicine team models her physiological trajectory over the next 72 hours. Without intervention, she may enter multi-organ failure. With staged abortion, her vitals can be stabilized and the uterus evacuated gradually under continuous surveillance. The patient is hesitant. She wants to preserve the pregnancy, hopes for fetal survival, and fears the implications of abortion. The team explains that the abortion protocol is not a termination of choice. It is a controlled intervention designed to avoid surgical trauma and allow for real-time response. Over 3 days, her cervix is prepared with laminaria, her blood pressure is managed, and her clotting profile is monitored hourly. On day 2, her platelet count drops further. A surgical extraction is ruled out. On day 3, uterine evacuation proceeds. The fetus is delivered without signs of life. The patient survives. Her liver enzymes normalize, her clotting stabilizes, and she is discharged after a week of observation. She later reflects that her initial resistance was rooted in hope, but the decision to proceed was rooted in survival. The abortion was not a rejection of life. It was a recognition of physiological limits and a choice to remain alive. Scenario: deferred intervention and the collapse of time. A 30-year-old patient presents to a hospital at 35 weeks gestation with elevated blood pressure, persistent headaches, and swelling. Lab results show early signs of HELLP syndrome. Her platelet count is dropping, liver enzymes are rising, and her clotting profile is unstable. The fetus is viable but in breech position. The care team recommends immediate intervention, either a cesarean section or a staged abortion protocol, warning that her condition may deteriorate rapidly. The patient is alert, articulate, and resistant. She expresses distrust of surgical intervention and discomfort with abortion. She insists she feels fine and believes that if things worsen, she can call an ambulance. She signs out against medical advice and returns home. She believes the fetus' optimal life comes with gestation. She also believes that third trimester abortions are medically unnecessary, given some pro-life rhetoric. Over the next 24 hours, her symptoms intensify. She experiences abdominal pain, vomiting, and visual disturbances. She delays calling for help, hoping the symptoms will pass. By the time she loses consciousness, her partner calls emergency services. The ambulance arrives 18 minutes later. En route to the hospital, she suffers cardiac arrest. Resuscitation is attempted, but she is pronounced dead on arrival. The fetus is not delivered. Autopsy confirms multi-organ failure due to undiagnosed DIC and liver rupture. The care team documents that intervention could have prevented maternal death had it been initiated within the recommended window. Risk profile: late pregnancy intervention due to maternal instability. Incidence of severe maternal morbidity (SMM) occurs in approximately 1.5% of all deliveries in the United States. Includes conditions like eclampsia, DIC, sepsis, cardiac arrest, and hemorrhage. HELP syndrome affects 0.5 to 0.9% of pregnancies, often in the third trimester. Can rapidly progress to liver rupture, stroke, or death if not managed. Disseminated intravascular coagulation (DIC), rare but critical, occurs in approximately 0.03 to 0.35% of pregnancies, often secondary to placental abruption, sepsis, or HELLP. Unrecognized pregnancy at third trimester. Estimated to occur in 1 in 2,500 pregnancies, often associated with lack of prenatal care, irregular cycles, or denial, delay in recognition. Given these facts, the aggregate adductive inference can be made. Third trimester abortions represent less than 1% of all abortions in the U.S., almost exclusively performed for fetal anomalies or maternal health emergencies. Circumstantial failures that elevate risk. Delayed recognition of pregnancy, no prenatal care, no fetal monitoring. Limited access to surgical teams, especially in rural or under-resourced hospitals. Legal or institutional delays, ethics board reviews, viability thresholds, or transfer protocols. Underestimation of maternal instability, symptoms dismissed, vitals not monitored closely. Clotting disorders not detected early. Platelet drop or liver enzyme rise may be missed until critical. Summary insight. While rare in absolute numbers, these scenarios represent high-risk thresholds that demand rapid, layered decision-making. The birther's survival often depends on early detection of instability, access to staged intervention, avoidance of incompatible surgical pathways. Now, not